So, good morning, everybody. I'm really delighted today to be talking to Dr. Jane Slater. Welcome, Jane.
Thank you. Hi, Marla.
How are you this morning?
Splendid. Thank you very much.
Good, good. What's the weather like down in Cornwall?
Oh, it's filthy. So I'm very glad to be sitting indoors. How is it up in Bristol?
It's kind of grey. It's grey, but it's, yeah, a little bit rainy, but yeah.
No such thing as bad weather, just the wrong clothes.
Exactly. So, wow, we got a really good response from the Facebook post about questions for you. So, I'll make a start and see how we go. So, what or who was your inspiration to become a doctor?
Yeah, that's a kind of curious question, and that's what they ask you when you go to med school for your interview. Why do you want to be a doctor? And everyone says, "Oh, because I want to help people." Actually, the reason I wanted to go into it was just because I was fascinated by gruesome things and gory diseases and horrible stuff. Yeah, so I told the truth at my interview, and they still let me in.
Right.
Yeah, so it wasn't a person or anything. It was just a fascination with things gruesome and gory.
And did that prove to be the case during your training?
Yeah, I discovered that I absolutely could not deal with gruesome and gory at all.
Wow.
Yeah, no, so it was kind of this idea in my head, but when the reality struck, it was quite different. So I mean, obviously you do have to deal with it because you have to, but it wasn't the fascination that was the big thing. It was that it was really difficult and unpleasant and kind of upsetting.
Wow.
So I didn't go the gruesome and gory way that I thought that I would have done, down sort of forensics and pathology, tropical diseases and all those kind of things. Instead, I sloped off quietly into general practice. You do still see some gruesome, gory things, but not so often.
You do. Wow. And how long have you been a doctor for?
Qualified in '84, but I'm not anymore because I retired in just at the end of 2016.
Okay.
Yeah, so I'm out of practice.
Right.
In all ways. Wow. So that's quite important actually, because obviously in 4 years a lot can change in medicine. So what I'm saying might be out of date, except that obviously death and dying doesn't really ever go out of date, only the way we maybe manage it. And that has also changed vastly over the years, hasn't it? So yeah. So I accept that what I say is my personal experience and how I dealt with things as a GP, and that might not be the experience of other people. Because one of the beauties of GPism is that you kind of get to write your own script. You don't have to sing somebody else's tune. So yeah, anyway, so I don't speak for GPs as a whole. I can only speak for me.
Yes, absolutely.
But I do know a lot of GPs who think the same way.
Right. Oh, that's good to know. Get that out in the open. So
yeah.
So in your training to be like a GP, a doctor, what did you learn about death and dying? What did they teach you?
Well, it's quite funny. As medical students, you have 2 days. 1 day is death and 1 day is sex. That's it. So yeah, I mean, I don't remember anything about the death day other than some crappy pictures that somebody had produced of crosses on hills and sunsets and things. It wasn't, I guess it was, maybe it was useful because, at 18, 19, 20, you hadn't really got much experience of it. So it was something, I suppose. But the actual learning is with patients, is with seeing how your older colleagues deal with and manage dying patients. And then in general practice, it got much better because then I was able to attend proper workshops run by the Macmillan nurses, which were brilliant. So yeah, but it is very much an experiential thing. You just watch and learn. See one, do one, teach one, as they say.
Say that again. Do one, see one, teach.
See one, do one, teach one.
Right.
It's slightly oversimplified, but that's the way most of us learn, I think.
Yeah, absolutely. Wow. Okay. And I guess it varies from doctor to doctor, isn't it, how they deal with.
Hugely.
Yeah, hugely. Because I remember when my mum got diagnosed with lung cancer, the doctor was, it's funny what you still remember that. I mean, that was 1980, goodness, what was it, 1985? And still remember, I mean, she got diagnosed with lung cancer, and she hadn't smoked for like 20 odd years, and the doctor was like really awful and just accusing her of smoking and stuff, and it's like, oh no, and it was like, oh, we always remember crikey. Dr. Bell. It was like, whoa,
so, it's little things like that he will have, it won't have meant anything to him, but it sticks with you like a thorn, doesn't it? It's terrible.
Yeah, exactly. So yeah, oh wow. So that kind of leads me into the next question. This is a question from Shakti, and she said, how do you feel when you have to give a patient the news that they are dying? And do you deal with it any differently if the person is someone you know personally?
It's always incredibly difficult. The process usually is that somebody from the hospital, from CT department or something like that, that's come across this diagnosis will phone through. It doesn't go through the normal sort of results thing. They actually do phone through to say, look, we found this grim looking lump or whatever, or a surgeon will phone through from theatre to say, we've just opened her up and closed her up because it's a no-go. So then I'm holding the baby then, and I have to make contact with the patient and say, can I come round sometime today? And do you want to have somebody with you? Even just, even recounting it now, it brings up emotions because it's really upsetting. So you get your act together, dry your eyes, and you have to go and tell them what you know. That usually is not well absorbed because people just don't hear what they don't want to hear. So for that first thing, I would tend to keep it small, just say, they've found this whatever, and it looks like it's cancer. I would always use the words, and we now need to look at how we're going to sort this out. So if it's a terminal thing rather than just a treatable thing, then I would probably hold a consultation at that point and not go into that stage, because first of all they need to hear they've got something really seriously wrong and integrate that and absorb it. So then I'd arrange to go back the next day or in a couple of days' time, and then talk a bit more about it and explore, okay, I've got the details here of the scan. Would you like me to read it to you and explain it, or do you want to ask me questions? And go with the patient's speed and with their level of understanding, their level of education. All sorts of things are really important to take it at their pace. So I mean, to answer Shakti's question, yes, it's very upsetting. It's affecting. It's really hard, and it's really important to do it well. I mean, as you found from your own mum, the wrong comments, not necessarily badly meant, but the wrong comment can just really fuck things up badly. So it's very important to be mindful of what you're doing and not of what you're feeling. So to be with the patient. I sometimes cry. that's okay too, because if the patient's crying, it's a human thing, isn't it? So I don't, that doesn't bother me. But I think at the same time, it's about the patient. So, you contain that, you dry your eyes and you get on with it. Does it matter about if it's somebody you know? Of course it does. I mean, quite often, you will have had your patient for 20 odd years or something. So it's a very different thing to telling somebody that you just, met a few weeks ago. Because it becomes then, there is a degree to which it's a personal loss as well. But again, that, you put that out of the way, because this is not about me, it's about my patient. So it affects us a lot. But it's something you just have to learn to manage and deal with somehow.
Wow. And are you offered like bereavement kind of support?
Oh no, God. No. I can't expand on that, because the answer is just no.
Because that's a lot, isn't it? Just imagine how many times over your career that
I mean, you can go and talk to your colleagues, because they'll understand. Talk to the cat, talk to the bees, whatever. What you don't do, of course, is talk to your friends or talk to your partner, because it's a confidential thing. So I could talk to one of the other GPs in my practice. That would be okay. I wouldn't be breaking confidentiality then. But it's.
Do you think it's needed? Do you think it's something that would be beneficial for doctors?
Honestly, I don't know, because I think there's a risk that you can get far too wrapped up in your own self with it. And that's just not what it's about. It's a part of the job. It's a difficult part of the job. Get on with it,
I know that when I was, it's funny, we've just had the anniversary of the death of a friend yesterday, and I had the great kind of privilege and honour to support her all the way kind of through the end of her illness, and then after she died. And again, it was really like, it wasn't about me. Like when I was supporting her, it's like I would show up, say, how can I support you? It's like it couldn't be about me. I would deal with my own emotions when I got home, or I'd get my own support separately, but that's not what she needed. She didn't need somebody kind of putting their stuff on her as well as trying to deal with her stuff. So
of course,
I can relate to that. So
I mean, I think for me, that's where places like Leela came into their own, is because here was suddenly a place where in a very, very safe and held environment, you could just let stuff go big time. So I think, self-care is really important. It doesn't come professionally in the job. You have to go and seek your own, whether that's through your God or your whatever, your garden or something. I found a lot of help through the meditations that Osho gave us. So great.
Brilliant. Wonderful. Okay, what's next on the list? Do patients actually come to you to talk about end of life planning?
Yes, I thought that was a really good question. And yes, and to answer the question that was asked there, yes, they do, absolutely, of any age. And the question that I received was, is it worrying or something when it's a young person? And the answer is yes, of course it's worrying, because young people on the whole don't think about planning their death. So if somebody young came to me to want to make an advanced directive like that, I would most definitely explore why they were wanting to do that, because my first thought would be, oh my God, they're thinking of going to top themselves.
Okay.
Yeah,
Right.
because it's not a common thing, but obviously, that wouldn't be my question. Why are you going to commit suicide? It would just be to explore in an interested way what's brought you, why are you thinking about that? And quite often it's because a relative has died and didn't have an advance directive and it was difficult.
Right.
Or they'd been on a death workshop or something like that, and there'd be some experiential thing that has brought them to that point.
Yeah.
And it's really important that I know it so that I can help to guide them through it all. But it is mostly the old and the ill that would do it, but we really encourage it. And in fact, in my own practice, we employed a nurse to go out to the people that were housebound, and actually get them to talk about it, and to write an advance directive so that people wouldn't be jumping up and down on their chests and resuscitating them if that's not what they wanted. And of course, if nobody knows, then you collapse and somebody's going to jump up and down on your chest. So it's really important that people do express not just things for cardiac resus, but things like, if they have a really overwhelming stroke, do they want to be tube fed, or allowed to slip off? Do they want to have antibiotics if they get an infection, or be allowed to slip off? So there's all those sorts of things. And of course, it's not the negatives, it's also the positives, because some people say, I definitely want to be resuscitated. I definitely want to be tube fed. I want everything.
Yeah.
And so those wishes need to be looked at and respected too. So an advance directive, I would want, in my ideal world, I'd have everybody do an advance directive and probably update it every few years. So I'm really keen, as I think most GPs are. And the really important thing for those people that have got an advance directive is to make sure that everybody knows about it.
Yeah.
And what we do down here is we make sure that everybody keeps it in their fridge, because pretty much everybody has a fridge.
Yeah.
So if an ambulance calls, they will check the fridge and see if that advance directive is there. And I think you mentioned that you've got a system where people have got proper little.
Yes, it's message in a bottle, and it's the Lions International Club, and you can get them for free. I mean, I think if people ask their GPs, because they're free for people. So, and you just put them in your fridge, and like you say, the medical team, they know to go to the fridge. Everybody's got one. So
they're very, very sensible and good idea. And it also it focuses our minds as well to think, I'm not here forever. At some point I am going to die, and this is how I would like it to happen, or not, or so it's very important. It helps families too. If you said, I don't want this, I don't want that, it takes the weight off a family when they're having to say, we agree to pull the plug. If you've written it down in advance, then it's a lot easier on people emotionally.
Absolutely. I mean, that's great that you're so on it. You were so on it down in Cornwall. I took mine to the doctors to kind of register, and the lady behind reception, she's like, what is it? What is this?
You're kidding.
No. So I kind of had to explain the whole thing, why it's important. She didn't have a clue. So it's really,
Did you contact the practice manager after that?
No, I think I will be though. Because
express surprise.
Sorry?
Express surprise.
Yes. And also it's like, I wonder, because my surgery, I don't know if it makes a difference if you're in a city. It's like we've got all the multiple doctors, so I really couldn't tell you which one's my actual doctor.
This is,
and it's that relationship, patient doctor relationship. So
I think this is a really bad thing that's happening at the moment. I mean, in our practice, we've kept what we call own lists. So my patients are my patients, and they will see me unless I'm on holiday or off sick. and if they don't want to see me because they don't like me, then they can very easily re-register with one of my partners. So that's fine. But that way, I know my patients, they know who they're dealing with. And it just, the whole thing becomes much more fluid, much easier because you know each other. I can't understand why there's this change to this, you know, see anybody thing, because it doesn't work, because you have to go through everything every bloody time. It's mad. It just makes life more difficult. I don't understand why people do it. It's just, brain dead fuckwittery, if you ask me.
Wow. And it's funny, one of my clients actually got in contact because we're on Advanced Directives at the moment, and she said that it's really been brought home because her neighbour in the flat downstairs, she's living with a terminal illness, and she's actually taken overdoses. And then, of course, the medics come round, they resuscitate, and she said there's just this perpetual cycle. She doesn't want to be here anymore.
Yeah.
Just like, whoa.
Yeah. I mean, for somebody with a terminal illness like that, I'm a member, a supporter of Dignity in Dying, which is a movement to allow people to have the death they choose at the time they choose, without having to go to Switzerland for it. I think it's everybody's right. And again, I cannot see, well, I do know why it hasn't been passed. It's because the House of Lords is populated over 1/3 by bishops. You know, the whole Christian culture thing gets in the way, which I think is crazy. Everybody's a right to their own beliefs. If they want to be Christian or Muslim or Jewish or whatever they want and believe what they want, that's fine. But, you know, don't foist it on me. So, I think everybody has a right to die at a time and in a manner of their choosing. Obviously, I don't think I would be happy to say that willy-nilly. I would want there to be some safeguards for all sorts of reasons, because we don't want people to be coerced. You know, old granny that is getting in the way a bit and is a bit smelly. You know, we don't want anybody to get coerced into that situation at all. So it would have to be with very, very careful safeguards. But it would, like this lady you're talking about, it's grossly unfair, isn't it?
Really, just needless suffering. Yeah,
exactly. Yeah, when there's no hope that she's going to somehow get over it, unlike, say, somebody that might be suicidal with depression, when there's a good chance that actually, you know, given some treatment support and so forth, they'll come out the other end and say, well, I'm very glad I didn't kill myself because now I'm happy. And I know it's not always that simple. But yeah, somebody with a terminal diagnosis, I certainly will, you know, if ever I get that, I shall ship myself off to Switzerland if I have to. I'm saving for it already.
Right.
Yeah, your chap that wrote on the Facebook page that talked about the Pegasus thing, I looked that up. Very interesting. So I'm exploring that. Hopefully not for a few years yet.
It's good. It's just good to know all the options, isn't it? And to know your choices. I think that's it. Like, people get to the end of their life and they don't know they've got choices.
Well, they haven't really, in a way. I mean, yes, you have got choices about where you die and what happens to your management and your treatment, of course. But whether and when, no. Just in case anybody's listening to this, we should mention that the two clinics in Switzerland. So Dignitas is the one that started it all, and Pegasus is the newer one, which apparently involves a lot less paperwork.
Right.
And for each of them, it's about £10,000 plus for the full package of being euthanized and then cremated, and having your ashes shipped back.
Great.
I mean, if you look at the price of a funeral, that's not bad, really.
No, exactly. Yeah. Like you say, if that's what the person wanted. So
Yeah.
Just reminded me of a question about, like, going back to the DNRs, about there being kind of pushed, like, about something being pushed forth on something. It was about the in the homes,
I heard about
like
that.
people with the older people, people with the oh, that's it here. Yeah, it's from Jane. Jane Diamond asked the question. I'd like to know if they welcome young people, our age, doing them, or are they falling for the terrain of the elderly and terminally ill?
Yeah, we've covered that bit. But the other thing is the coercion of, of older people. Yeah. I mean, that's utterly unsupportable. And while, again, you know, we always want our patients who are in homes, or well, anywhere, anybody that's old, we want them to have it so that their wishes can be respected. But that's an opportunity for you to say what you want. It's not a means of saying, well, you don't want this, do you? And you don't want that. I mean, that's wrong. The other thing that needs to be explained to people is also an advanced directive like that. When we're talking about not resuscitating, what we're talking about is specifically, if your heart stops, do you want somebody to be jumping up and down on your chest? That's what DNAR means. Do not attempt resuscitation. It doesn't cover the other bits, you know, like if you have an infection, do you want antibiotics? If you have a stroke, do you want to be tube fed? So those are all part of an advanced directive, but they're not DNAR.
Right.
But that should be explained clearly to somebody so that they can then make an informed choice. I mean, I'm going to say, for most old people, resuscitation is not going to work anyway. You know, death is normal, and you can't resuscitate somebody out of death all the time. So it is a bit of a no-brainer, to be honest.
Yeah. I mean, I've got a friend who's just started like a care agency, you know, like the living carers.
Yeah.
And when she went on her training day, they said they do not take on elderly people who don't sign the DNR. They have to sign the DNR to in the agency.
To be taken on the. Well, I mean, as the agency, that's, you know, that's their right to say that.
Okay.
You know, as long as they make it clear up front to any clients, you know, if you want us to look after you, that's a ruling for us. It seems a bit of an odd one, but on the other hand, as I say, you know, if you're dealing with very old people die. We all die if we get old enough, and even before we get old enough, if you're not lucky. It's a crazy culture that we've got into, of feeling that we have to try and stop somebody from dying. I mean, obviously sometimes it's appropriate, but a lot of the time it's not.
It's not a failure.
And exactly that. The whole system and our whole culture has come to view death as a failure instead of as a culmination of life, and that's tragic. And the best death I ever attended was, I was called out to a very old lady. She's in her 90s. I was quite a young GP, so I'd only known her about 2 or 3 years. And her neighbour was there and had called me and said, you know, she's collapsed. Her neighbour was caring for her. And there she was, the telly was on, flat out on her sofa, deeply, deeply unconscious. So we had a little chat together about this was all before advanced directives had even been invented, what she would want and what she liked and all the rest of it. yeah, the neighbour said, and there's no way that she would want to be carted off into hospital and messed about with. And knowing her, even just the couple of years I'd known her, I'd be certain would be true. So yeah, we had to make an on-the-spot decision just to sit and wait and hold her hand.
Wow.
And she died, I don't know, an hour or so later, I suppose. But it was beautiful. It was a really good death. She died watching the telly, just conked out. And yeah, I mean, obviously examined her and all the rest of it to check there wasn't anything that was reversible, but yeah, she obviously had a massive stroke, and she slipped away beautifully. It was great. So yeah. The sort of thing that you would welcome given the chance. I would welcome anyway.
Yeah, me too. Yeah, that's an interesting question, isn't it, about how would people want to go? And it's
well, actually, one of the questions on the page was about that. Is what was it? Do you want to go fast or live long or something?
Yes, let's have a look.
Or what's a good death? I can't remember. It was a chap that asked it.
That's
Howard,
right.
was it?
Oh, Norman. Yeah,
Norman, right.
Yeah, have there been any times when you thought, now that's a good way to go? You just said.
Yeah, well, that was what prompted me to remember that one. Yes.
Yeah, and which would you prefer, a quick death or a longer life? Oh, interesting.
Yeah. I would go for a quick death. I don't want to linger. And interestingly, my experience with patients, and part of the reason for my support for dignity in dying is just that. Most people would prefer not to linger.
Yeah.
And I've been asked so many times in my career to, can't you give me something, doctor? And I have to say, no, I can't. I'm sorry. I would like to be able to for you, but yeah. So quick, not long for me.
Okay. I'm going to see if I've missed any questions here. How can we open up to communicating more around death and dying?
With things like this, I think. I mean, I think it's up to all of us as individuals to talk to one another, to talk to kind of talk to ourselves, recognize, we are going to die, talk to our families. God, that's the hardest thing, talking to your parents and trying to help them because my mum's 89 now. She's kind of cleared the house out, so I don't have to do that come the time.
Wow.
But yeah, really engaging in that conversation of pre-planning is so important, and it's really difficult. I haven't got a recipe for a way to do it that's not really difficult. You just have to accept that it is.
Yeah.
And I would always counsel somebody to kind of make a plan to do it on purpose, not something that just slips in.
Okay.
But actually say, look, I think I would really like the opportunity, if you would like, to be able to talk about this. Do you want to talk about it? If the answer is no, then you can't.
Yeah.
That's that.
Yeah.
And if the answer is yes, then it's okay. Well, shall we meet up on a week on Tuesday? Give us both time to have a think. And then actually, yes, kind of structure it quite seriously, because that way it is a bit easier to ask difficult questions.
Right.
But I would really encourage people to do that. The other thing I think is really important is to use the words dead, dying, death. Don't fanny around with this passing away and stuff. Again, experientially, if you say to somebody, I'm very sorry, you come out of the room into the sitting room where the family's waiting, Mr. So-and-so has died. It's clear, the guy's dead. And I've come across situations with patients before when they've, somebody's come out and said, it's all over. And they didn't really know what that meant. Had he had an injection so that he wasn't in pain anymore, or what? So
Right.
it's very, very important. And for doctors, obviously, but also for patients and for human beings to use the words, to be clear. What do you want to happen when you are dying?
Yeah.
Yeah, so vital.
Yeah. Yeah, because we do we use all the euphemisms and
yeah, it just obfuscates the truth, and it also gives us the message that it's not quite nice to talk about, and it's a bit embarrassing, and we just have to get over ourselves. We're going to die, all of us. Let's do it well, or as well as we possibly can.
Amazing. Yeah. Wow. I've got one more question.
Yeah.
This is from Andrea Shruti. She says, thinking of Dr. Shipman, does it make you high when a soul leaves the body?
Yeah, I read that question, and I wasn't quite sure which way around she meant it. Dr. Shipman was a murderer who happened to be a GP. So what he felt around things, I don't know, because I don't personally know any murderers. I haven't met any yet. So I can't answer a question from that point of view. Does it make me high? Well, no, of course not. That's a kind of weird concept, so no. But I wasn't sure if she meant, does it make the patient high? Because there are a lot of things about near-death experiences where people do plainly feel very high and wonderful. So I don't know. We'll have to wait and see, won't we, on that one?
Okay.
All of us.
Yeah.
I hope so.
Oh, thank you so much, Jane. It's been absolutely brilliant talking with you today.
Great to talk to you too. Thank you very much for the time. Thank you for this project you're doing, because I really think it's important. And I so enjoyed your funeral director last time. It was brilliant. I wish she worked down here. It's a good reason to move up to Stroud.
There you go.
Yeah.
Oh,
anyway,
lovely.
Great to talk to you. Go well. Have a good rest of week, and bye-bye, everybody.
Thank you. Yeah. Bye, everybody. Thank you.
Bye-bye.
Bye.
And go to Leela. Go to Leela.
Yeah.